said, this is a very rapid and non-invasive tool, correct? It is very easily available. It can be done either in the X-ray room or you can do it bedside, even in the wards and the intensive care. But very important thing is interpretation is very, very crucial because especially in the neonatal and the pediatric age group, the X-ray, gastrointestinal X-rays, they will give you a lot of good information to you. And just by good reading of the X-ray, you can make your diagnosis and you can proceed with the further management. Also, these X-rays will guide you what is going to be your next imaging modality, whether you need any advanced imaging modality like CT scan and MRI, although they have a limited role. But by looking at these X-ray, you can probably take a call that what next modality will be required. And we all understand that there is a very limited role of advanced imaging, especially in the neonatal and the pediatric age. And we all understand that all these advanced imaging, especially the CT scan, they give a lot of radiation to the child. So we normally avoid getting all these investigations done and try to limit the radiation dose to the pediatric patients. So a good X-ray intervention, a good X-ray interpretation will help us in early intervention. Like if X-ray on X-ray, just on the X-ray, if you're able to make a diagnosis of pneumoperitoneum or intestinal obstruction, you can immediately advise for the surgery and you can proceed with the intervention. And so as a result, you can have a good outcome rather than waiting for further investigations or waiting for the child to get further deterioration. So by good reading, you can intervene early and accordingly you can proceed and that will give you good outcome and good results. So for any imaging, this slide is very, very relevant because whenever you are doing any imaging and you are reading any imaging, you should be able to know the basics. You should be knowing the basics of imaging and you should be able to, you should be having a systemic approach to read that image. So when you are reading an X-ray abdomen, you should be aware of the relevant anatomy. You should be able to understand the pathology. You should be knowing that what is normal, what is abnormal in this X-ray, and then you will correlate that pathology with your clinical interpretation. And also after the correlation, then you can make a differential diagnosis. So by reading the X-ray, by analyzing the X-ray and correlating it clinically, you can make a differential diagnosis and then accordingly you can plan your management. So like in this X-ray, if I'm seeing this X-ray abdomen, the first thing I would like to see the gas pattern, how the gas pattern looks like, whether it is uniform or it is just localized to one particular part of the abdomen. How are the solid organs looking like? Like if you see the X-ray abdomen, you will get the shadow of the liver, shadow of the spleen, whether it is enlarged or some abnormality is seen, like calcification is seen in the solid organs. Then you look for the bony shadows. So sometimes, especially in neonatal age group, you can have some congenital bony abnormality. Like in this X-ray, you can see there is a absent sacral vertebra. So there is a sacral agenesis in this X-ray. So all these findings should be seen in a systemic approach, and you should not be missing these findings. When the child is in ICU, there could be multiple lines and the tubes inside the abdomen and chest. So all those tubes and the lines and their positions should also be interpreted in the X-ray abdomen. So this X-ray, you can see here that there is abnormality in the bone and there's an associated sacral agenesis. Now, what kind of view you are taking is again very important. So as a surgeon, we always prefer that we should have an erect film, which sometimes may not be possible, especially if it's a newborn baby or if a child is in the in intensive care. Supine film is obviously the most commonly ordered film, but especially if you're trying to rule out the problems like obstruction or pneumoperitoneum, or if you want to see the gas pattern, it's preferable to have erect film to make a diagnosis of these pathologies. So I don't find any advantage of getting supine film as well as the erect film done. So just to save the radiation, it is always preferable. If possible, you should take a erect film so that you should not be missing the problems like obstruction or pneumoperitoneum. Decubitus film is also sometimes ordered, especially in newborns and infants in ICU when you are suspecting pneumoperitoneum and you are not able to take a erect film. So you can see the gas under the abdominal wall, and for that we advise the decubitus film. Cross table lateral view. It is ordered, as you see in this image, that this is a child with anorectal malformation, and we have taken a cross table lateral view instead of invertogram, which we use, which is now obsolete and which we used to do before. And by doing the cross table lateral view, you can see the distal rectal gas, and then you can assess what will be the type of anorectal malformation. Sometimes air acts as a contrast media, and by injecting air, it itself acts as a contrast, and then you can probably have a better delineation of the obstruction, especially like upper duodenal atresias and jejunal atresia. So just you can put some amount of air to the nasogastric tube, and then you can have a better delineation of the pathology. So this is erect film taken, correct? And as you can see here, there are multiple air fluid levels. They are mainly in the upper abdomen. If you see the pelvis, there's hardly any gas in the pelvis. So this is highly suggestive of intestinal obstruction, mostly involving the small bowel. And if you take this film in a supine position, you might not be able to see these air fluid levels, and you might miss the diagnosis. Similarly here, you can see there's a lot of gas-free air under the diaphragm, and which will be only be seen if you take a erect film. So this is the relevance of the erect film when you are suspecting any surgical pathology in acute abdomen. This is a lateral decubitus film taken in a newborn baby. You need not to have a erect view, and when you take a lateral decubitus film, there's a lot of air you can see here below the anterior abdominal wall. Now, this is a child who had obstruction, and this is a supine film which was taken. Correct. So, as you can see in this supine view, that although the bowel loops are looking abnormal, these are the small bowel loops which are dilated, edematous, but no air fluid levels. So, this additional finding of air fluid level can be missed if you are taking a supine view. But yes, of course, it may not be possible in a sick child. It may not be possible in a newborn baby who is already on ventilator in intensive care. Now, it is very important to have a clear visualization of what normal skygram abdomen looks like. So when I see this when I see this normal skygram, you can see here on the right side, there's a liver shadow, there is splenic shadow on the left side, there will be gastric bubble on the left upper abdomen below the diaphragm. Then there will be uniform gas pattern. So I see the gas pattern here. I can't see any dilated bowel loops. There's a patchy gas seen all over the abdomen. There's a gas in the rectum. There's no paucity of the gas, and there's a uniform distribution of the gas. Similarly, here also, in this X-ray also, you can see that there is a gas present in the pelvis, in the whole abdomen. There's a liver shadow. There is a stomach bubble seen with an air fluid level, which is normal, normally seen in the abdominal X-rays. So this picture should be kept in mind whenever you're reading any abdominal X-rays, and then only you are able to identify any pathological findings on the X-ray. Now, this is an X-ray of the newborn baby. So if I see this X-ray, I can make out that there's a uniform distribution of the gas all over the abdomen, which is classically described as a honeycomb pattern of the gas. There is a gas present in the rectum also. Okay, so this gas pattern is very, very important to understand. Secondly, when I'm seeing this X-ray, it is important, especially in the newborn baby, that it is not possible to differentiate that which is the small intestine and which is the large intestine. So the gas, you cannot differentiate that which is gas is seen in the small intestine and which is in the large intestine, especially in the newborn baby. So in this X-ray, as you can see here, there's a uniform distribution of the gas. But yes, it is difficult to make out that which gas is in the large intestine, but which gas is in the small intestine. But usually the peripheral gas is in the large intestine, and the central gas pattern is seen in the small intestines. So besides this, I would also like to see that There are a lot of tubings here. There's one tube in the stomach. Then there is a UV catheter, which is lying here. Probably there's catheter in the bladder also. So you should also look for all these tubings, whether they are positioned properly or not whenever reading the X-ray. So when I'm seeing a bowel gas pattern, I should look for whether there is any focal distension or not, whether there is abnormal distribution or not, whether the gas is present in the upper abdomen only, or there's absence of gas in the lower abdomen, which will help you in knowing the level of obstruction, paucity or too little gas, and also air fluid levels. Now, this is the gas pattern which is inside the intestine, but there can be gas which can be lying outside the intestine also. So obviously any gas which is outside intestine is abnormal, and and it can be in the form of hemoperitoneum. Sometimes it can be intramural gas, which we call as a pneumatosis intestinalis, and also, as you see in patients with necrotizing enterocolitis, you can find a finding of portal venous gas also, which can even you can see on the X-rays. So this is how you see the extraluminal gases, and that also you should always look for when you're reading X-ray. Now, this is an infant coming to us, presented to us with the complaints of vomiting. And when we're seeing this X-ray, you can see there's a hugely distended stomach. There's a nasogastric tube lying inside the stomach, and there is very little gas beyond the stomach. And also, you can see there's a peristaltic wave which is seen across the stomach. So this is a hyperperistaltic stomach, distended stomach with large amount of gas, probably suggestive of some kind of obstruction at the level of pylorus. And if you correlate it clinically with the child who is an infant around 1.5 months old with such kind of picture, is a very high likely diagnosis of infantile pyloric stenosis. So this was a child with a pyloric stenosis. Now, when I'm saying, when you're reading an X-ray, as I said, you should not be missing the extraluminal gas. So if I see this X-ray, I can definitely make out that this is not a normal gas pattern, as I have already described in the previous X-rays, which you see as a uniform distribution of gas, honeycomb pattern, with stomach air. But this X-ray is not looking abnormal. It is looking very, very abnormal to me, with very patchy streak-like gas pattern seen along the bowel loops. So this is not an intraluminal gas, but this is an intramural gas, which is along the intestinal bowel wall. So this is intramural gas in a patient with necrotizing enterocolitis, where the gas is lying within the intestine bowel wall, and this is usually as a result of the severe infection which you see in the patients with necrotizing enterocolitis. So this is a condition which, if you see the X-ray, it should not be missed. These findings should not be missed, because this is seen usually in a critically ill child who might require surgical intervention, because most of these patients, they will have bowel ischemia. Similarly, this was another infant who had the similar findings. He presented with severe gastroenteritis with X-ray abdomen showing bowel loops. But very important finding which was missed in this X-ray was the gas seen in the liver. So this was the gas which was lying in the portal vein, and it was a result of the severe gastroenteritis, and this gas got absorbed from the intestine into the portal vein, and you can see there's a portal venous gas here. So this patient, I operated for I suspected intestinal gangrene, but none of us could make this diagnosis of liver gas in the portal vein. But when we saw the X-ray retrospectively, we could make out that yes, there was a gas in the portal vein. Now, I said tubes and lines are again very important. So when I'm reading an X-ray, I should also look for the positioning of the tubes and the lines. So if I see this tube is a venous catheter, umbilical venous catheter, which is going higher up in the chest. Most of the time, it should be somewhere at the junction of the atria and the IBC, but the position is not normal, and it's quite higher up, and it needs to be repositioned. Similarly here, this is a coiled nasogastric tube line. So this was a child with a tracheoesophageal fistula with blind ending esophageal pouch, and there was a coiled nasogastric tube in the upper pouch. So by looking at this X-ray, I can, and by correlating it clinically, I can make a diagnosis of tracheoesophageal fistula. And once I make a diagnosis of tracheoesophageal fistula, I would also like to see how the lungs are looking like, whether there is associated pneumonia or not, whether there is any abnormality in the limbs. Sometimes there can be vectoral association with tracheoesophageal fistula. How's the spine looking out, and how's the cardiac shadow looking? So all these findings you can always try to look for whenever you are making some abnormal finding, abnormal diagnosis. Now, this X-ray, there's a free air on both the domes of the diaphragm, correct? But another very abnormal finding, if you see this X-ray, is that this is a nasogastric tube which is going till pelvis. So this was a child who had a large gastric perforation because of this nasogastric tube, and the tube went into the pelvis, and that led to the pneumoperic. Now, this is another abdominal X-ray. As I said, you should also look for the soft tissue shadows. So if I see this X-ray, you can make out that the abdomen is hugely distended. This is not a normal scaphoid abdomen, but it's a hugely distended abdomen. The bowel loops are pushed on one side, and then there is a large soft tissue shadow here, correct? So, and if you look carefully, you can see some calcification here. In this area on the left upper abdomen, there's a calcification area, and there's a large soft tissue mass. So clinically, you have palpated the mass. X-ray showing the calcification. In a newborn baby, there's a very high possibility that it could be a teratoma. So this child was found to have a large abdominal teratoma, which was arising from the pelvis, and which was showing the, which was also having the calcification, which you can see on the X-ray. Now, neonatal intestinal obstruction is something which is very commonly diagnosed in our neonatal intensive care unit. And you should always, before seeing the baby, before making a diagnosis, before seeing the X-ray, you should always know the differential diagnosis of neonatal intestinal obstruction. And you should be knowing that what is the level of obstruction in the various conditions. So there can be a gastric outlet obstruction in pyloric atresia, duodenal obstruction in duodenal atresias, malrotation, annular pancreas. Jejunal-ileal obstruction is seen in the patients with jejunal-ileal atresia, meconium ileus, total colonic aganglionosis. And colonic obstruction is seen in Hirschsprung's disease, anorectal malformation, and colonic atria. So we should be aware of all these differential diagnoses before we are interpreting the X-ray abdomen. So, तो
लेन बैक लेन है ना, अच्छा तो क्लीन करता है। मान लो कोई ऐसा काम अटक जाता है ना घर का, तो नाली चौक हो गई, फिर नाली है मतलब क्या
people other than
the phone.
Yes, yeah, I'm muted. Sorry for the disturbance.
Okay, so sorry for that, but like if like this is a newborn baby who presented with a bilious vomitings. When the child was seen in the nursery, there was no obvious abdominal distension, but there were bilious aspirates. Antenatally, there was a history of polyhydramnios. So if you see this X-ray, we can just see there are two small air bubbles here. This X-ray was taken almost immediately after the delivery, and there's two small air bubbles here. That is the position of the nasogastric tube, and absolutely gasless abdomen. So there is no gas beyond these two levels. So this is a very classical picture of double bubble sign, which we see in the patients with duodenal atresia. So this is a classical double bubble sign. Although there is a very small gas seen in the stomach and the duodenum. So what we can do here is you can put some more air to the nasogastric tube. And this will help you in further confirming your diagnosis. So there's a large, after putting air, you can see here, there's a large air bubble in the stomach, there's a large air bubble in the duodenum, but absolutely no air seen distally. So there's a hugely distended stomach and duodenum with absence of gas distally, which is very classical presentation of duodenal atresia, and that is a double bubble sign. So the child was operated, as you can see here, that this is a hugely distended duodenum, and then this is a atretic segment here, and there is a distal duodenum and the jejunum. And this child required duodenum. Now, similarly, as you can see here, again, the child had bilious vomitings. There is a mild upper abdominal distension. If you compare with the previous X-ray, it's a mild upper abdominal distension. 3 bubbles, 1, 2, and 3 bubbles, and then there is a cutoff, and absolutely gasless abdomen below. So this is a sign called as a triple bubble sign, which is a classical feature of jejunal atresia. So as you can see here, there's a hugely distended jejunum. That's the atresia, and there's a collapsed bowel seen beyond the atresia. So this child required again the resection of the atretic segment and resection anastomosis. Now, this making a diagnosis in such kind of X-rays can be challenging. Now, here you can see is a multiple dilated bowel loops. There are multiple air fluid levels also, and there's a distended abdomen. So this is a most likely there's a small bowel obstruction, because there is a uniform distribution of gas till the lower abdomen with multiple air fluid levels, and then there is an absence of gas in the pelvis. So it means there could be a possibility of the distal small bowel obstruction. Now, whenever you get such kind of picture and you're suspecting distal small bowel obstruction, there could be multiple possibilities, and that's why the diagnosis can be challenging. So one possibility is ileal atresia. The other is it can be a long segment Hirschsprung's disease involving whole of the colon. Then sometimes there can be meconium plugs lying in the distal small bowel. So this picture you will get in the meconium ileus also. And sometimes it can simulate the picture in a patients with necrotizing enterocolitis, where the picture is like a paralytic ileus, where you will see some small air fluid levels, and then it can be necrotizing enterocolitis. So obviously you have to correlate with clinically, and also when you are not able to confirm your diagnosis, you might have to proceed with the further investigations. So this child was diagnosed to have ileal atresia. The child was explored, and there was a atresia at the distal ileum. This picture, you can see there's a hugely distended bowel with a large air fluid level. And this is a very classical picture of colonic atresia, or sometimes you get the similar picture in the patients with anorectal malformation having pouch colon. So this was a huge colon, that was a hugely distended colon, and that was the atretic segment. So this was a patient with a colonic atresia. So now I'm sure that you should be able to make a diagnosis by looking at the X-ray that what kind of atresia it could be. There's a double bubble sign, duodenal atresia, triple bubble jejunal atresia, multiple air fluid levels with absence gas in the pelvis, intestinal ileal atresia, and this is a colonic atresia with large air fluid. Okay, now this is another case scenario. Again, the presentation is very similar. This child is presented with complaints of bilious vomitings. There's a mild upper abdominal distension. There's a double bubble sign. There's a dilated stomach, dilated duodenum, but it's not a gasless abdomen. There is small patchy gases seen in the distal, in the upper abdomen, but there's no gas here in the pelvis. So sometimes you get such kind of picture where you will have a double bubble sign and there is a paucity of gas distally. So if this is the scenario, there could be two possibilities. Either this is a malrotation where there is a duodenal obstruction, but the continuity is there. Secondly, it could be a duodenal web or duodenal atresia with perforation. So there is a diaphragm in the duodenum with a small perforation through which a small amount of gas will go in the distal intestine, and you can see small patchy gas with a paucity of gas distally. So double bubble sign with the gas distally, these are the two differential diagnoses which could be possible. So if just few slides on malrotation. Like in a malrotation, what happens is, instead of normally what we see in a normal child is the DJ should be lying on the left side of the spine. So this is stomach, this is duodenum, this is jejunum. So this is a DJ junction, duodenojejunal junction, which is lying on the left side of the spine. But in malrotation, the DJ lies on the right side of the spine. And because of this, there is a formation of the Ladd's bands, which causes the duodenal obstruction, which leads to dilatation of the stomach, dilatation of the duodenum. Child will present with a bilious vomit. So if you see the X-ray, you will see a double bubble sign with some amount of gas distally. But if you want to further confirm your diagnosis, you can always proceed with the dye study. So that's the upper GI contrast study, which was done in a child with suspected malrotation. There's a stomach dilated, there's a duodenum dilated, and the jejunal loops, which should be lying here on the left side, they're lying on the right side. So the DJ junction is on the right side, which is very classical presentation of malrotation. Similarly, in this picture, the DJ is lying on the right. So that's the jejunal loop starting here, DJ lying on the right side. And these are the patients who will require immediate intervention. So this is a finding which should not be missed, because if you miss these findings, some of these patients, they might land up with the intestinal volvulus. So malrotation, I would say, is a true emergency, and this is a finding which you should not miss. You should correlate clinically and see the X-ray carefully. If required, you can do a contrast study and then proceed with the surgical intervention. So this sometimes, as I said, these patients might have intestinal volvulus because of the short mesentery, and this volvulus can be dangerous and life-threatening, and intestines might lose their viability. This was a child who presented with just a small air in the stomach, the absolutely gasless abdomen, and the abdomen was tense with severe peritonitis. We thought that most likely this is a peritonitis, and when we operated, it was a malrotation with a whole intestinal gangrene. So malrotation is a true surgical emergency, and you should not miss the findings of malrotation on abdominal X-rays. Now, most of these newborns with intestinal obstruction, they will not have dilatation right from the birth. So dilatation will be progressive. So when you see the child on day one, there will be minimal dilatation or no dilatation, and gradually as the air goes into the distal intestine and the colon, the dilatation will start increasing. So air takes some time to reach the large bowel. So normally it takes around 6 to 8 hours to reach the distal intestine, around 12 to 18 hours to reach the large intestine. So if you're taking X-ray, if you're taking immediate X-ray, you may not be able to get the you may not be able to get the findings, and you may miss the important findings. So it is always better that if your child is stable, you should always delay the X-ray so that gas can reach distally, and then you can make your diagnosis. So all these patients will not have abdominal distension right from the birth, and they take some time to develop the distension. Now, this child had progressive abdominal distension on day 3. You can see the hugely distended abdomen on the X-ray with dilated small bowel loops. So possibilities could be ileal atresia, Hirschsprung disease, meconium ileus, NEC. So these are the 4 possibilities with such kind of scenario when there is a generalized abdominal distension with dilated small bowel loops. So now, as I said, when you are not able to make a diagnosis, you might need some further investigations to confirm your diagnosis. So looking at this X-ray, we thought that either it could be ileal atresia or it could be a total colonic aganglionosis. So what we did was a contrast study. So this was a contrast gastrographic study which was done. It was an enema study, and as you can see here, there's a rectum, sigmoid, there's a descending colon, and as you are approaching towards the transverse colon near the splenic flexure, the transverse colon was getting dilated. So that was a dilated transverse colon. with a transition zone somewhere here, and that's the collapsed distal colon. Picture very much suggestive of Hirschsprung's disease, which is a long segment Hirschsprung's disease. So if you are not able to make a diagnosis, you can always take the help of a contrast studies, which will help you in confirming your diagnosis. Similarly, here, as you can see here, the hugely distended abdomen, dilated bowel, all the small bowel loops are dilated, no gas in the pelvis. We did a contrast study, and what we could make out here is there's a transition zone at the junction, almost at the mid-sigmoid area, and then proximally the whole colon, which was normal ganglionated colon, was distended. So again, a very classical picture, as you can see in the patients with the Hirschsprung's disease. Now, these patients who are having small bowel obstructions, so their colon usually gets collapsed and it remains unused, and that is what we call as a microcolon. So in patients with either total colonic ganglionosis, ileal atresia, meconium plug, this is unused colon, and this is how the unused colon looks like when you do a contrast study. So it's completely collapsed colon, unused, and what we call as a microcolon, which is suggestive that there is some small bowel pathology which is causing the unused microcolon. Now, another scenario here, that this child is having distension right from the birth. Not a progressive distension, but there was a distension right from the birth. And when I see the X-ray, there are no obvious air fluid levels which are seen. There are dilated bowel loops which are present. Some loops are dilated, some loops are not very much dilated, but there is no air fluid levels, and there is a paucity of the gas in the lower abdomen. And if you see carefully, there is some soap bubble type of appearance in the right lower abdomen. Now, there's also another important history in this patient was the antenatal scan, which was showing the echogenic and the dilated bowel. So when you get such kind of scenario with echogenic and dilated bowel, with abdominal distension, which is present right from the birth, X-ray abdomen showing no air fluid levels, but dilated bowel loops and some sort of soap bubble appearance, this is a very classical scenario seen in patients with meconium ileus. So there are meconium plugs lying in the distal small bowel, and because of these thick plugs, there is no air fluid level. So the meconium is very viscid and tenacious. So because of that, you will not get a classical picture of obstruction which you see in the patients with normally, which you see in the patients with intestinal obstruction, that you get obvious air fluid levels. But here in meconium plug, normally you don't get the air fluid levels. And but yes, if you correlate the child clinically and if you know the classical appearance of X-ray on of meconium plug, then you should be able to make a diagnosis. So this is a child with a meconium plug, and doing a gastrographin enemas in these patients is not only diagnostic but also therapeutic, because the gastrographin is a hyperosmolar agent, and what it does is it absorbs the water from the what it does is that it helps in liquefying the meconium plugs which are lying inside. The plugs usually absorb the water, the gastrographin absorbs the water, and then this plugs gets liquefied, and then this helps in child. These liquefied plugs, then they can pass spontaneously, and this obstruction might get. So using gastrographin is not only diagnostic and therapeutic, it's a hyperosmolar agent, absorbs water, liquefies the plugs, and then child passes plugs spontaneously. So as you can see here in this diagram, there's a plugs lying here in the distal part of the small intestine. Proximally, the intestine is distended, and because of these plugs, the child is having distension and intestinal obstruction. Sometimes they might require a surgical intervention also. Sometimes there could be antenatal perforations, and these perforations can lead to calcification. These perforations might get sealed off, or sometimes they might present as peritonitis or intestinal obstruction. So there's a newborn baby with the calcification in the abdomen, which was suggestive of antenatal perforation. Now, these are the 4 conditions where you see the abdominal distension since birth. Number 1 is meconium ileus, meconium peritonitis, abdominal lump, and the ascites. So if the child is born with a huge distension, there could be one of these possibilities. And you should all try to rule out one of these possibilities. Now, newborn with acute abdomen, pneumoperitoneum is the commonest cause of acute abdomen. And as you can, as I already mentioned, you can do a lateral decubitus film to confirm your diagnosis. Necrotizing enterocolitis, I have already described. There's an intramural gas here. This was not a newborn, this was an infant who presented with severe necrotizing enterocolitis with severe septicemia. And this was the X-ray abdomen, which is showing, you can see here, there's a intramural gas present. And that's the CT which was done, which is again showing the presence of the intramural gas here and also gas in the liver. And when the child was operated, the large segment of the intestine was ischemic and gangrenous. This is again pneumoperitoneum, the gastric perforation with the gas under diaphragm. This is child with pure tracheoesophageal fistula, the coiled chest tube seen here in the upper esophageal pouch. So when there's a tracheoesophageal fistula, you should always see that whether the gas is present in the abdomen or not. Because if there's a gas in the abdomen, it is a type C fistula. So gas goes through the fistula into the stomach. But if it is a pure esophageal atresia, where you will have a blind ending esophagus, then it will be absolutely gasless abdomen. And so by knowing this fact, one should be able to make a diagnosis that what kind of fistula it is. So that's the child. You can see here, absolutely gasless abdomen with gas shadow seen in the left chest, left hemithorax. So whole of the small and the large intestine, they are lying in the chest because of the large diaphragmatic defect. So here the abdomen will be scaphoid. There will be gasless abdomen. The intestines lying in the left hemithorax with a mediastinal shift. Now, sometimes you can get similar picture in a child with the CCAM. Correct. CCAM also will have multiple cystic spaces in the X-ray. And if you see the X-ray chest only, then the picture will be very, very similar. But if you see the abdominal X-ray, then you can probably able to make a diagnosis that the abdominal X-ray, there is not much gas inside. So there could be a possibility of CDH rather than CCAM. And if required, you can order a CT scan or to confirm your diagnosis. So I would like to conclude here. There are many other X-rays through which, like in the patients with Hirschsprung disease, anorectal malformations, how to interpret those X-rays, again, also very important, but I'm not going to cover that aspect today. So I would like to just conclude here. And X-ray abdomen is very, very important diagnostic tool, especially in the pediatric and the neonatal abdomen. And most of our diagnosis related to gastrointestinal anomalies can be just made by reading a good X-ray. And interpretation should need an orderly approach. One should be able to interpret what is normal gas pattern and what is abnormal gas pattern. And that's how you can make your diagnosis. If required, you can do additional contrast study, which can add on to your information. Thank you so much.
Thank you, Dr. Prashant, for a very elaborate and detailed presentation and showing us the importance of the humble X-ray. Now I invite our chairperson for their inputs.
Yeah, hello, Dr. Prashant.
Yes.
Yeah, sir. Hello.
Yeah, it was an excellent presentation. Very good, very nice. I think you did a better job than any radiologist could do it.
Nice, sir. So
The images also were very good, and the talk also was very informative. And I think this would have added a lot of value to the people who are in the forum who are watching this presentation. Fantastic, very good. I have
thank you.
few comments to make.
Yes.
One is, I know it is very difficult to take an erect view of the baby, especially newborns and pediatric age groups. But if at all we have to take one film, then I think it would be better to take an erect image, which will add value and give you more information in terms of air fluid levels and gas under diaphragm and other things.
Correct.
And the second point was there was this one image that you showed in which there is this colonic atresia.
Correct.
Yeah, colonic atresia, yes, and this image could also be similar to what we see in cecal volvulus.
Correct.
Okay, so
Yeah.
you can have this coffee bean appearance with the neck
Yes.
extending
Yes.
to the
Yeah.
pelvis.
Correct.
So though it is though chronic atresia would be very common in a newborn baby
Yeah.
and other
So
people.
correct. So
So
cecal volvulus is
cecal
not that common in the pediatric age groups and newborn patients.
Yes, cecal volvulus, we don't see that much in much early pediatric age group, maybe later and adulthood, yes, of course. So
Agreed.
that's important. And the one point that I would like to comment upon is that gas in the liver and the portal vein. I think this is a very, very important slide. Very important, and people should be sensitized to, because it's like, it's your eyes see what your brain or your brain knows. Okay,
Correct.
so it may be the gas may be staring at your face, but your attention will not go there to interpret that as a severe condition which could point towards a very important diagnosis.
Correct.
So I think people should be. That was a good slide, and I think people
Correct.
should go back to the
So
slide
in
and have a
fact,
look.
this was the X-ray done in our ICU itself, and
Yeah,
we were not able to make a diagnosis on the X-ray. Correct. The child
yeah,
was not improving, having severe signs of peritonitis, which you can see
mm,
sometimes in the patients with acute gastroenteritis. And then we
yeah.
thought let's go for a CT scan because taking the
Okay.
child for the surgery will not be easy because child was already taken on
Mm,
aneurysm. So then when
yeah,
we did a CT, we could able to make a diagnosis that it was an intramural gas, there was a portal vein
yeah,
gas, and then we
yeah.
operated.
Yeah, that's a very important slide. I think people should go and have a relook into that, and probably sensitize oneself towards finding gas in the portal system is a very ominous sign. It's very,
Correct.
very severe and serious a sign which should be picked up, should not be missed. And of course, we know
True.
in practical day-to-day time we miss it and pick it up on CT.
Correct.
So I
Correct.
think to that sensitization is very important. The other comment that I would like to make is all malrotation cannot be picked up on an X-ray.
True.
So malrotation can only be picked up on a contrast study.
Hmm.
So if you find like that one X-ray you showed where there was only one gas bubble in the stomach and the rest of
Hmm.
the abdomen there was nothing,
Correct.
you could see nothing out of that. It was a case of a malrotation. And I think one should not restrict oneself. If you are not able to find a diagnosis on that, go for a contrast study and
Yes.
probably reinforce the diagnosis on that.
True, true. In fact,
So,
sometimes instead of going for contrast study, we can order one ultrasound also because
yes, yes, that's what
ultrasound
I,
will get
yes,
the reversal of relationship between SMA and SMV, which will again
yeah, yeah.
confirm your diagnosis of malnutrition.
Yeah, yeah. Yeah, I can yeah, I know ultrasound should be freely used because it does not have any limitation. It is easily available. It can be done portable, and it's easy to do. I think ultrasound should also be freely used. But since the
Correct.
topic was X-ray, I think you did a great job. There was this
Thank
question
you.
how to do X-ray in NICU, erect X-ray. I think there is no choice. For erect X-ray, you have to come down because we need a bucky for that. So stand for that. So you'll have to come down to the X-ray department to get an X-ray
Yeah. So,
erection.
in case if the child is very sick and you can't shift the child in the ICU, then maybe you can have you can do X-ray in a semi-erect position, not at
Yes, we can still do it in the bedside, putting up the
bedside in a
cassette in a
semi-erect.
way that the baby is standing up, erect, is made to, sort of holding the child. And we
Yeah.
can do that
However,
in the
yeah,
NICU
semi-erect
also.
position
It's
will
not
not be possible in the ICU. That's true.
NICU, still we can do, we can try. I don't think that's not a problem. It's not a problem. We can still do an erect view in the ICU with the cassette on the back of the child. Putting the only thing we need to take care of is the radiation protection for the people who are handling the child and the
Correct. Correct.
X-ray technician who is handling the cassette.
Yes.
You need to take those lead aprons and other things that needs to be used.
Correct.
So excellent presentation, Prashant. Well done. Great
Thank you.
job.
Thank you so much. Thank you.
Great.
Thank you, sir. Dr. Ravi, would you like to add
Ji,
something?
Ji, yes, sir. Good afternoon, everyone.
Good afternoon,
Excellent
Dr. Ravi.
presentation, sir. You
Thank you.
almost covered everything. Sir has already covered almost everything. I don't have anything much to add. Only thing is just when you are looking at an X-ray, it is always good as you look at ECG, means it is always better if you look it in proper sequential manner. So it is always useful if you look at organ wise, quadrant wise, and sometimes look at the foreign bodies. Foreign bodies means anything. What are the lines that are going in? If they are air in the extra air, in unusual space. So, sir has already covered most of the conditions. So, in day-to-day practice, it is important to, delineate the etiology and whether it is normal pattern or abnormal pattern. So I would just add to it that just start looking at X-ray in a more, sequential and more organized manner. Yeah, that's it.
Yeah, very rightly said, Dr. Ravi. More we see, more we start picking up abnormalities.
I also
Yeah.
have one more comment,
Yes.
Prashant.
Yes, sir.
I think there is one more thing that we should hold ourselves back. Since the availability of ultrasound, CT, and MR has been there always, it's always easier to jump to the other modality, and try
Right.
to get more information, and
Yes.
and especially in a defensive medical practice, you tend to go around doing some more
Correct. Advanced imaging.
investigations.
Yes.
I think we should consciously hold back on that.
True. So doing advanced imaging like CT, MRI is not very much feasible because it is shifting the child to CT or MRI. MRI might take a very long time. Then additionally, you will require some kind of anesthesia and sedation for these patients, which can again add on to the risk. So yes, of course, if it is indicated, obviously you will have to do it because there are conditions when we order for the MRI and the CT scan. But especially for the gastrointestinal problems, uh, especially for the newborn babies, especially the babies who are in the ICU, the X-ray can give you a lot of good informations if you approach them in a sequential manner.
Yeah, that's right.
Yeah, fair point, sir. Yes.
So there are no more questions in the chat box. So I would like to thank Dr. Prashant for making
Thank
the
you.
topic so interesting and the detailed presentation. Big thanks to our chairpersons for sharing their valuable time and sharing their expertise at this platform. And thank you all the audience. And next month we will be back in BLK Telepeats webinar series with another interesting topic. Good afternoon.
Thank you so much. Thank you. Good
Thank you,
afternoon.
ma'am.
Thank you.
Thank you, ma'am.
Thank you so
Thank you,
much.
sir.
Thanks a lot. Thank you.